right, thank you, and thank you to the organizers for letting me come today and talk to you a bit about our project. So I did just arrive in town this morning, and I'm sorry I'm a little hoarse. I think I left my voice back around the international date line, but I'll do my best. Hopefully you can hear me. So we have a project that hopefully you will find interesting, one in which we're attempting to deal with some of the challenges which I know you face here. So in the United States, we have a growing population of cancer survivors, a good problem to have. We've had better and better survivorship over the years. So as this chart shows, we've have a growing number of survivors, and it's projected to get even larger. So we've tried to respond as a cancer center to help me frame up this project that we're doing. We've tried to respond as a cancer center to some of the proposals that have been made through the NIH, the Institute of Medicine, the CDC, and other groups over the last several years, and moved to establish our own comprehensive and clinic-specific survivorship program within the Cancer Center. So striving to achieve all those things, which I know all of you are, to improve adherence to surveillance and screening guidelines, improving coordination of care in a multidisciplinary sense, and improving long-term health of our survivors, both physical and psychological, so that we can eventually have an improved duration and quality of life. So our program has been focused around our traditional areas of work, and we've included elements of research, also being multidisciplinary in our design of our program. So we've maintained a site-specific approach utilizing the multidisciplinary approach we do on the treatment side. And this has been supported by significant operations infrastructure. We've been able to get our leadership on board with this, to connect in with broader education of our clinician community and the teams that help support them through lots of communication. So over the last few years, we've established a large number of site-specific cancer survivorship clinics. So patients come into a space separate from their routine follow-up clinic. We've had a clinic for our childhood cancer survivors for some time, as you can see, but the others are more adult-focused clinics that we've established over the last few years, utilizing our faculty interested in survivorship management and teams led on the clinical side by our PAs and nurse practitioners for the most part. So our activity has grown over the last several years. We've continued to see larger and larger numbers of survivors, but we're beginning to reach a maximum point just because of space, and being able to see more survivors down the road, which we expect is going to be very difficult for us. So we've become very interested in understanding how we can address survivorship needs by collaborating with the primary care community. So we recognize there are clear limitations on this sort of model that we've established. It works well where we have it, but there are limitations in space. It's hard for some people to get back to Houston. I mean, we get patients from many, many parts of the state and the country, so some have trouble traveling. And the challenges that we have, as I'm sure many of you do, in just collecting and maintaining the information and infrastructure has led us to really look seriously at how we connect better with the primary care community. As we look at the sorts of patients that we see in our survivorship clinics, we have assessed that they tier out into different groups. Some are very high risk of recurrence, require continuous management, often are on recurrent medications or continuous medications that require very close follow-up. Others are the ones that we're seeing right now in our primarily in our survivorship clinic. Those that have some risk of recurrence is moderate. They may have some need for specialized services, such as the cardiac challenges that we were talking about a little bit earlier. So they may be better managed in a subspecialty setting. But a large number of them are those that have low risk of recurrence. They don't have any real serious problems right now, and they can easily be managed, and in fact are managed in primary care settings right now, although the primary care teams may not necessarily see them as cancer survivors. They're just another patient in their practice that has had cancer. So this is a project we put together with funding from our Cancer Prevention Research Institute in Texas, and this has allowed us to do this as a demonstration project. So our aim is to improve the use of evidence-based preventive services in adults in these primary care settings. We're using family medicine residency training programs as the clinics that we're focused on, with the idea that we can provide, demonstrate that we can provide service in these clinics, but also to train the next round of physicians as they come through. So we're fortunate to work with a number of our other colleagues there at MD Anderson. This is a program that is one that really requires their community partners. So we found 3 willing participants amongst the 30 different programs that we have in Texas. So they were brave enough to step up and work with us, and they're located in Galveston, Texas. Houston is right there in the sort of lower corner. Where Houston is similar to Melbourne in its location, in a lower south central part of the country. So one of the programs we work with is in Galveston, which is just very close by. It's a University of Texas Medical School program. The other is in Austin, Texas, and that is associated with a new medical school, the Dell Medical School, that we have there. And the other is Tyler, Texas, which is far in northeast Texas. So these are all relatively different in their setups. Their sizes are similar. These are 3-year training programs. And the one in Galveston is connected with a med school, but there's not a lot of interaction with the oncology group there. The one in Austin is connected with a med school, but it's a brand new med school. They're just getting up and getting started. They don't have a cancer center in Austin. They receive referrals from many different clinicians. And the one in Tyler is a very rural setting. So but it does have a small cancer center which is affiliated with our University of Texas system. So they're all very different. They bring different ideas to the table, and it's been interesting working with them to see those variations. So our ideas here were to really have the clinics go in and look at use their EHRs to find the cancer patients in their practices. They didn't really know who they were, but really kind of take a look-see, generate a registry so that they would know who they are and would be able to use that information to trigger interventions such as preventive services or regular follow-up visits for the other components of survivorship. So we've asked them to attempt to acquire from the oncology service or develop a treatment summary and care plan. In our baseline survey, there were very few of these present. So even though we're supposed to be disseminating these, all of the hospitals now in the U.S. are supposed to be disseminating these, they're not penetrating at least into these practices. The other is to develop some sort of collaboration with the local community clinicians in oncology, and the results there are quite variable, but at least they began to develop this collaboration with the Med Center and MD Anderson. So we've tried to use various techniques to address their needs and knowledge and their confidence. We felt confidence was an important factor, that they should feel comfortable taking care of these patients. And we've used some somewhat innovative approach in doing that. In addition to online materials, we've used a program called Project Echo, which will have has nothing to do with the cardiologist. It's this community extension program that came out of the University of New Mexico was originally developed to help primary care doctors treat patients with hepatitis. So it's an interesting program. It's tele-mentoring, not telemedicine. We're not treating the patient for them. We are connecting with them, providing them support, and you can link up with all 3 practices at once to provide brief didactics and share case-based learning and learn from each other. So it's an interesting approach, and the little rapid fire tomorrow talks about that briefly. So these are the approaches that we asked them to do. So basically, practice-based changes using their EHRs to identify and trigger, to turn on the flags for follow-up care, and to get them established in a routine management plan to address the primary areas of cancer survivorship within their clinics. So to provide primary, secondary, and tertiary prevention, much of which they're already doing for a lot of their patients, but to do it within the framework of a care plan for survivors. Then the telementoring, as I mentioned, is using the Project ECHO approach. We've also adopted this to use for teaching primary care doctors how to follow up on abnormal pap smears, pain management, and palliative and supportive care, and have become a training center for the ECHO program for cancer-related use of the ECHO platform. So we put together a number of other education materials, online programs through our oncology education effort, and some of these were also funded by CPRIT. We put together a textbook that has been more of an academic tome, but one that covers the primary areas, and we work with our clinicians in the clinic to address clinical interest for people to look at. We've had around 25,000 chapter downloads from this thing. It really seems to be something that people are interested in, and we're coming out with a new version, more of a, in the U.S. we call it Washington Manual, but more of a clinically oriented direct how-to manual, a little less didactic, and we'll see if that one is of interest too. So both the original one and the new one will contain our treatment algorithms. So we have a robust collection of these where we try to use a simple flow chart so the clinicians can come in and look to see what they need to be doing for a given patient in surveillance, in screening for second primaries, in managing late and long-term effects, and dealing with psychosocial issues. So they're all lined up basically like this, and we have attempted to boil these down based on best evidence to help provide some guidance for clinicians on how to manage their patients. So we'd hope to, as part of this, to see increasing numbers of survivors with treatment summaries and care plans, increasing the number of the providers who are reporting that they're very confident in their knowledge and their abilities to manage cancer patients, survivor patients, and to increase the degree to which we can deliver services that are recommended as part of those guidelines, and hopefully to increase the number of patients who are receiving some regular conversation about what they should be receiving in terms of ongoing care. So these are the results that we've seen. We're a bit surprised by the low baseline. Now, I understand these are residents, these are trainees, so in a sense, I think it tells us that they're not getting a lot of this in medical school. But at least we were a bit surprised that the numbers were so low to begin with. These are, if you're familiar with it, these are based on the questions from the Spark survey that was done a number of years ago, but it's looks at community practicing physicians, which and their numbers were a bit higher. But we've seen some progress, very good progress in some. I was tempted to report this in percentage increase rather than the actual numbers, but I decided maybe that wouldn't be fair to say we had a 250% increase. But so these are the real numbers. So, but it's getting better. So we're seeing improved numbers in knowledge in various areas. We're seeing that they're more confident in their knowledge across different types of survivorship management issues, and we're seeing that in both breast cancer and colorectal cancer that they are answering the knowledge information-based questions more effectively as we've repeated the survey from year 1 to year 2. So we're participating, we're hoping that our participating clinics will continue to be able to utilize their office-based systems to improve care of their patients. And we have found that that's beginning to happen, although there is some variation from clinic to clinic. We've seen improved confidence in knowledge and skills, and we have seen the idea that they are beginning to provide guideline-based care to their cancer survivors in a measurable way. So we hope we'll see better interaction with the local oncology community as time goes by. So thank you very much.